Hello, my name is Dr. Jeffrey Spiro from the Division of Otolaryngology, Head and Neck Surgery. This is another one of the videos that we're using as background information for the CoRE C5 problem on oral cavity and oropharynx cancer. Now, along the suggested reading list, I did reference a couple of articles, or actually website pages from the American Head and Neck Society, one on the oral cavity and one on oropharynx. Contained within these are discussions of staging, but you need to be aware that the staging that's discussed in those pieces is the staging from the AJCC 7th edition. The 8th edition was just released at the beginning of the year. It will not go into effect, however, until the beginning of next year. However, the changes that have been made, I think, are very interesting and are something you should be aware of. And I'd like to talk about them without going into too much detail. To begin with, the oral cavity cancer staging system has been altered. The vermilion of the lip has been shifted to the skin cancer staging system, which makes a lot of sense because it is related really to solar exposure and not to the typical risk factors for oral cavity cancer. One of the things that has now been introduced into the T staging system is depth of invasion. Now, as we'll show you in a little bit, depth of invasion is not the same as tumor thickness. The other thing that's happened, that there's been a slight alteration to the T4 staging category, which you don't really need to worry about. And most importantly, the stage groupings, in other words, which combination of T and N and M staging gives you which particular clinical stage, have not changed from what you encountered in the references. Depth of invasion is something I will show you shortly. It's measured from the level of the basement membrane to the closest adjacent normal mucosa. You draw a line and drop a perpendicular plumb line from this plane to the deepest point of tumor invasion. And it's stratified by every 5 millimeters of invasion is a different category. So this would look something like this, and two different examples here where you can see the horizontal line at the level of the basement membrane, then the perpendicular line labeled as depth of invasion, and you contrast it on the left side with the white line, which is what probably would have been measured previously as tumor thickness, which is obviously a very different concept. So we are looking at depth of invasion in the new AJCC staging system for the oral cavity. And this reflects clinical work that's been done in the past that demonstrates a clear correlation between the depth of invasion of the primary cancer in the oral cavity and outcomes. And that's the purpose of all staging systems, is to try to correlate this. The thing to realize, of course, is that this information may not be available ahead of time before there's been an actual resection of the cancer. So just to refresh your memory, this is the AJCC 7th edition, and you can see that the only criteria was surface extent, breakpoints being at 2 and 4 centimeters, as you can see listed, and as you should have already encountered in the references. And this is the T4 list here. So here, the big difference here is that, and I don't expect anybody to memorize this, but you can see that depth of invasion has been added as a criteria. The point being that you can have a lesion that's still small. If you look at T2, for example, where it says tumor is less than or equal to 2 centimeters, but as a deeper depth of invasion, it now moves up to the T2 category, reflecting, as we said, our actual experience clinically with cancers in the oral cavity. And there's been, as I said, slight change here on the T4, which is not particularly crucial, but I did mention as well. The oropharynx, this is where there have been profound changes in the staging system, and we've been talking about in this module the fact that we have almost 2 different diseases when it comes to squamous cell carcinoma, the HPV-related disease and the more traditional non-HPV-related disease. Well, this has been recognized by the AJCC. What they found in the past was that applying the 7th edition staging for HPV-related oropharynx cancer led to very little distinction in outcome between stages 1 up to even stage 4, particularly when staged pathologically. So what they did as a result was they now split the pharynx into 2 categories. HPV related, or we'll call it HPV positive, and the traditional HPV negative categories. If there is less than 75% staining or weak staining to P16, which, as we've talked about, is the surrogate marker for HPV, then the cancer is considered HPV negative. So there are significant changes for the HPV-related disease. The only change for HPV positive, the only change for HPV negative disease is some alterations to the end staging system, which we will touch on briefly at the end of the talk. So now we have a whole new HPV positive oropharynx category. The T4A and B distinctions have been eliminated. In the end staging system, the nodal size less than 6 centimeters and number of nodes becomes much less relevant when compared to the traditional end staging. So, by the way, the T staging otherwise has not really changed clinically for the oropharynx. Pathologic end staging has changed as well. This new consideration of extranodal extension does not apply to HPV-related disease, and the stage groupings have changed quite considerably as well. And I think the best way to look at that is just to do some head-to-head comparisons here. For example, the oropharynx end staging, this is nodal involvement. On the left, you see the traditional end staging that we've used really for all sites in the head and neck except the nasopharynx for many years. And then we have the new, on the right, the new HPV positive end staging. Where you can see it's quite different. You can have any number of lymph nodes on the same side as the cancer, as long as they're not bigger than 6 centimeters, and that's just N1 disease. And you can read the rest for yourself. This is, I think, very useful as a head-to-head. The TNM stage groupings are shown here, and this also represents a very big change. For example, the only way you can have stage 4 disease now for HPV-related oropharyngeal cancer is to have disseminated disease, distant metastasis, as you can see on the bottom left. The only stage 4 disease is that which has M1 or known distant metastases. Otherwise, the highest stage you can have is stage 3. And you see also the differences here across the board. You can just compare one side to the other. There's been a dramatic shift, if you will, to lower stage for HPV-related disease, reflecting the more favorable prognosis of this particular type of cancer. So this is not something I expect you to memorize, but I think it's just something that I think is very instructive and illustrates from a prognostic standpoint the significant differences between HPV-related and the traditional HPV-negative carcinoma of the oropharynx. Lymphatic metastases has also been changed. The concept of spread of cancer outside the capsule of the lymph node, which we had in the past called extracapsular spread, but is now really called extranodal extension, or ENE. This has been introduced into the end staging system. I don't want to get bogged down in this too much, but this is a bit of a throwback because now we're taking into account clinical correlates of more extensive spread of disease in the neck, as you can see described here. These are things that have a high bar to meet, but are now being recognized, at least in the clinical staging. And we can talk about the pathologic staging briefly as well. Well, coming up right here, it's now extranodal extension is now part of the pathologic end staging. Although, as we said earlier, this is not being applied to HPV-related oropharynx cancer. Once again, just for your information, there's now different categories of extranodal extension. The presence of this increases the end stage. This is a new thing again. So you look at the 8th edition of the clinical end staging, the only real difference is down at the bottom when you compare it to what you've already encountered, which is that there's now an N3B category, which is clinically overt extranodal extension, which, as we said, is a tough thing to document, but we showed you some of those criteria. However, pathologically, it gets much more complicated, and once again, I don't expect anybody to memorize this, but just be aware that pathologically, the presence of extranodal extension has been incorporated into the end staging system, and as we said, if you have extranodal extension, it basically shifts you up one category on the end staging pathologically. So these are things that we just wanted to put out there to show you, I think, primarily to demonstrate how HPV-related disease in the oropharynx is really being recognized as almost a different disease entity in the newest edition of the staging system, which will go into effect on January 1st of next year.